Good morning, everyone, and warm welcome to the second resource launch from the CancerX project focused on digital innovation to improve equity and address financial toxicity. My name is Sarah Sheen. I'm a program lead at the Digital Medicine Society, or DIME, and partner to the CancerX initiative. We are really pleased to have you all here today and to be able to share the health system resources we've been working on for the better part of a year now. Before we do so, I'd like to walk us through a bit of housekeeping. I'd love to preview the agenda for the webinar with you all, and of course, share a special note of thanks to the team that made this happen. First note here, participants are discouraged from sharing intellectual property or competitive information during today's session. As a reminder, the session today is being recorded and will be accessible on the DIME site after launch, alongside the slides you see here today from the great speakers we've got lined up. We've got a wonderful agenda for you all today, a great group of speakers here to talk us through the context for the work and to share the resources and their impact on health system operations and decision-making. Many of these speakers you see on your screen were part of the broader project team that partnered with CancerX over the last 18 months on this first project. It is not an exaggeration to say that we could not have done this without the support and the brain trust of the CancerX project team you see on the screen here today and of the broader CancerX membership. They helped us scope the project. They gave us data to support the work, and they really answered 101 questions about how these tools can most effectively help in the real-world cancer setting. I also wanted to thank someone in absentia here. I am co-program lead and co-program head of the inaugural CancerX project on equity and financial toxicity, alongside Corinne Leach from the Moffitt Cancer Center. Corinne is on a boat in the middle of the Atlantic and could not be here, unfortunately, for the launch of the resources today, but was such a reliable partner in their development. And we thank her in absentia and hope when you tune in, Corinne, you're proud of what we've done today to launch these resources. Finally, and importantly, I'd like to give thanks to the folks that set the vision for this work from Moffitt and from DIME, even before CancerX was established. One of them is here to kick us off today. I'd love to introduce Jennifer Gould, CEO of the Digital Medicine Society, to give us some introductory remarks. Jen, I'd love to pass it over to you here.
Wonderful. Thank you so much, Sarah, and thank you for the opportunity to be here and celebrate with your team the incredible work that you've done and that today you're making available to the community. So as Sarah said, my name's Jen Goldsack. I'm the founder and CEO here at the Digital Medicine Society, or DIME, and proud co-founder and co-host of CancerX. When we think about the mission of DIME to advance the ethical, effective, equitable, and safe use of digital technology to redefine healthcare and improve lives, and then think about how that relates to the mission of CancerX, to think about harnessing the power of digital innovation to achieve the goals of the Cancer Moonshot. These are bold and intimidating sort of goals for us to have. And when we first took on with our colleagues at Moffitt, our colleagues across government, and now 200 bold member organizations who share our commitment to the mission of CancerX, it's a lot to take on. I deeply believe in the need for us to achieve the goals of the Cancer Moonshot, reducing the number of deaths from cancer by 50% in 25 years, and making sure that the burden of cancer is no longer as inequitable as it is. I deeply believe in the power of digital innovation to help deliver those goals. And so when you bring together this community, where do you start to make sure that you are doing the best work in pursuit of that mission? I am incredibly proud of the vision and courage of every single organization at the table at CancerX to say we must start by making sure that everything we do as part of this community takes every single person that we can help with us. It is absolutely a non-negotiable that we start at the intersection of cancer, digital innovation, and equity. And that's so much of what you see in the resources that we are launching today. We also don't stop there. I think one of the trademarks of our community at DIME, one of the trademarks of CancerX, and the uncompromising nature of all of our partners is that we're not just looking for a single bottom line. We want a double bottom line, a triple bottom line. And what we also see in the resources that we launched today is that as we think about applying high quality, trustworthy digital solutions to cancer care and research, we can advance a digital strategy, the commercial strategy of a health system. We can also reduce inequity in the way that we care for people with cancer. And we can also reduce the sort of financial toxicity that far too many patients with cancer suffer as a consequence of their diagnosis. I love the way that this team and this community has been uncompromising and frankly written the blueprint, not just for patients with cancer, but a whole mindset toward digital innovation, that we can have outsized impact when we are intentional, that we can have outsized impact when we bring a community together, and we can have outsized impact when we take a data-driven approach. I want to thank every single member of the project team, not just for joining us within the CancerX community, but by sharing our vision and our commitment to being uncompromising in our focus on equity as we do this work. As you listen to the talks today, as you review the resources, as hopefully you take them away and use them, I am confident that you will find enormous value to your own strategies, to every single patient that your organization exists to serve, and to the lives of every individual that at CancerX we hold so dear as we pursue all of this. Sarah, congratulations to you and Corinne for leading such an exceptional team and exceptional efforts. I'm incredibly excited to hear the stories from leading experts around how these resources were developed and stories of impact, because that's what we're here to do, here to make a difference. So Sarah, let me hand it back to you. Congratulations to everyone again. And let's all take this forward, this notion that when we are intentional, we can have outsized value for every single person. Sarah, all yours.
And thanks so much for the introductory remarks here. We are really, really excited to share the resources with the group. And given that context, I'd love just to share some data points about the issues we were up against in the project and our approach to addressing them. Over 50% of cancer patients experience financial distress after a diagnosis, and over 42% of patients spend their life savings in the first 2 years after treatment. Many of these same patients, and disproportionately cancer patients from minority groups, face unnecessary hurdles in access to specialized cancer care. We view these as hallmark failures of the American healthcare system. So we set up a research plan to identify an effective fix alongside all of those project partners you just saw on the prior screen. We leaned on evidence generated from a systematic literature review we conducted in one of our prior work streams, as well as a semi-structured interview series to deduce that patient navigation is one of the most and one of the only effective interventions in reducing financial toxicity and increasing equitable access to cancer care. My colleague Brian Gonzalez from Moffitt Cancer Center will be on in just a few minutes here to discuss further the impact of patient navigation on outcomes and operations. In this provider interview series that I just mentioned, we heard time and time again that patient navigation is not properly prioritized, it's mostly ad hoc and analog, and that it's hard to scale, but that health systems do it because it's the right thing to do. These resources were born out of those conversations. We knew there was a role for digital health solutions here to increase health system capacity to do the right thing, to deliver patient navigation services to the patients that needed it. We also knew that the field would need resources to make this happen, to make a business case for digital patient navigation, as well as reliable guidelines for how to implement patient navigation that leverages standardized workflows, existing technology, and new payment pathways. We are really pleased to share the resources with you all today. There are 2 of them, and they complement the 3 resources released from this project last November, which are available on the cancerx.health website and clickable through this link in the slide here. The 2 that we're releasing today start off with the CancerX ROI Calculator, which is a customizable decision-making tool that quantifies the impact of digital patient navigation solutions on measures that matter to health systems. The CancerX Blueprint is a guide for the design and implementation of digital patient navigation programming in a way that maximizes that ROI, that minimizes provider burden, and that overall improves patient outcomes. We have a great crew to share more about the resources and their impact up top at the beginning of the session. We've got Brian Gonzalez, Associate Center Director at Moffitt Cancer Center, Carl Ash, Executive Director of the Pharmacotherapy Outcomes Research Center at the University of Utah, and Jake Centra, Research Manager here and my colleague at Dime. Brian, I'd love to pass it over to you for just a set of intro remarks on the impact of patient navigation.
Thank you, Sarah. I'm excited to speak today about some of the benefits from leveraging digital patient navigation, and I'll briefly review some strong research evidence pointing to meaningful benefits, not only to patients, but some benefits that are also very relevant to hospital systems and other clinical providers. But before we go on, you want to keep in mind that most of this research is really based on more traditional or analog models of patient navigation, like Sarah mentioned. And most of the historical research did not have the benefit of the resources that we'll describe today. And I say that to mention that leveraging the digital patient navigation tools that are themselves empirically supported are very likely to further enhance the reach and the impact and the cost effectiveness of cancer patient navigation. And before I share some details on patient navigation, I'd also like to point out that these studies were based on these papers are based on studies from a very varied set of clinical context and clinical providers, including small and community oncology clinics, academic tertiary cancer settings, and very large healthcare systems. And so we feel like these are very robust settings that we can refer to confidently demonstrate the impacts of these findings. And these findings were also observed in very diverse patient populations, both in terms of demographic characteristics and in cancer context. So on the next slide, you'll see start with some clinical context, some clinical impacts that we'll want to emphasize. And so patient navigation expands access to cancer screening. And this is shown in the context of clinical cancer screening, such as helping educate and coordinate screening for patients who might not be up to date currently on routine cancer screening. This is also shown in the context of improving screening for secondary cancers. On the previous slide, yes. So in that context, secondary cancers are a significant contributor to cancer burden, and improvements in the area of secondary cancer screening would have huge benefits too. Another benefit is that patient navigation improves access to timely cancer care. This means shorter time from screening to resolution of diagnosis. And as many of you know, cancer diagnosis is often not a one and done approach. There are many patients who will have to have multiple follow-up tests and appointments just to even get a firm diagnosis. And navigation has over and over been shown to shorten this time significantly. It also helps patients get to start treatment sooner. There are many logistical and clinical and other barriers that can hinder a patient with a cancer diagnosis from getting started with treatment. But navigation has been shown to accelerate the time from diagnosis to treatment, which in many contexts, that time savings can be a huge benefit to them in terms of survival. There's also studies that show that navigation can enhance a patient's access to trials, which provide their best chance at a cure. And lastly, numerous studies have shown that patient navigation can overcome socioeconomic barriers to cancer care. For example, some studies have shown that there are large disparities in access to care among patients with fewer economic resources or with less informal caregiving support. But the power of patient navigation helps overcome these disparities to level the playing field for all patients. On the next slide, we'll see some impacts above and beyond the direct benefits to patients. There are also some benefits of patient navigation that are very salient to hospital systems and other provider systems. Cancer patient navigation results in greater patient retention, partly due to better patient quality of life and improved patient satisfaction among those who receive navigation services. And those patients also have fewer emergency room visits, fewer hospitalizations, and shorter length of stay when they're hospitalized. This results in providers having, of all kinds, having more time to focus on their top of license care, devoting less time to dealing with what are sometimes preventable toxicities and more time on complex cases. And so you will no way be surprised by the fact that these many benefits of cancer navigation are resulting in studies showing that they're also cost effective. And this is all before some of the technological advances that you'll see today that can enhance the reach and impact of digital cancer patient navigation. Thank you, Sarah. Back to you.
Thanks so much, Brian. We really appreciate the context here. And now that we've set the stage for the impact of digital patient navigation, we'd love to be able to preview some of the tools we've built to increase the access patients might have to that digital patient navigation. So I'll be happy to run through the first tool we've got up for you all, the CancerX ROI Calculator. And if you'll just give me a second here to share my screen. I'll give some notes on the audience for the calculator and the process we undertook to build out the calculator. The calculator is meant to be used by stakeholders that purchase or sell digital solutions to support comprehensive cancer patient navigation. This is a tool for end users, health systems, and insurers alike who want some clarity and extra confidence around their decision-making to invest in digital solutions to support patient navigation to address equity and financial toxicity issues. The conceptual framework that we're working here for the ROI calculator, and the literature bears this out, is that patient navigation enabled by digital tools does a few things. It decreases financial toxicity, and that decreased financial toxicity improves medication adherence, and that improved medication adherence reduces healthcare resource use and spend. I'm really, really excited by this tool. I think it's really neat to be able to share out. And before I do that, I can't go any further without thanking the team that made this tool possible. A huge thanks to Carl Ash, who will speak after me, his team, CJ Tan, and Ishfaq Rashid at the University of Utah and Huntsman Cancer Institute that built the backbone of this calculator, a health econ model that really shows and quantifies the value of digital patient navigation solutions on measures that matter to health systems. So let's run through it. You're able to initiate the model, the calculator, by plugging in your OR profile and moving to the next module to set your values. After you initiate the model, the calculator, we hope it's clear that you can set the values in the tool based on your system specification and data. If you don't have some or any of that data, you're free to use the CancerX estimates we've generated in all or some of the sections. You'll still get a reliable ROI figure at the end of the model, and the methods for these estimates, these CancerX estimates, are spelled out in the hover over boxes throughout the tool. So in the first section here, you're able to populate the medication adherence parameters in the calculator using your system specifications to get clarity around your baseline rate of non-adherence driven by financial toxicity and what kind of proportional improvement you might be able to expect in adherence after digital intervention. If you're not coming with your own data here, you are free to use the CancerX estimates. In the next section, you're able to set cost data. So let's say that you are assessing or maybe even marketing a digital patient navigation solution. You can input the capital and operating costs of implementation in this section, or you can use the CancerX estimates, which are based on data donated by cancer support community. Finally, based on your input, the calculator will output data on the healthcare resource use reductions you can expect over a 5-year period per patient and in total across your healthcare system. These cost savings on the right are inclusive of reduced length of stay, so number of hospitalization days, and reductions in the number of outpatient visits. This part is customizable if you know the total cost of a hospital day or an outpatient visit within your system. Ultimately, these cost savings are offset by the costs you inputted for the implementation of the solution, and a total ROI figure is generated. You can edit your input directly from this page, and you can download the results to share with your colleagues as you make a business case for digital patient navigation. So now that we've got a handle on the tool, I'd love to have Carl Ash walk you through its impact in healthcare decision-making. So please, over to you, Carl.
Thanks very much, Sarah. Thanks very much, Brian and Jennifer. That being said, before I get into the weeds a little bit about the utility of this calculator for healthcare decision-making, I wanted to backfill some of what Sarah and Jennifer and Brian has already said. Essentially, patient program navigating is definitely proven already effective in helping facilitate equitable access to cancer care. Yes, it does serve to reduce financial toxicity. It helps to improve health and quality of life outcomes for cancer patients. However, resource limitations do indeed impact the ability of healthcare systems to scale patient navigation programs to meet the comprehensive care needs of their patients. Healthcare systems, such as Moffitt and other healthcare systems, can potentially leverage digital solutions to address capacity and efficiency issues, and therefore help reduce administrative burden for both oncologists and patient navigators. However, I'm a health economist, so I have to say cost is often cited as the single largest barrier to investment in digital health solutions and in patient navigation programming. So it has been established that these type of digital solutions may indeed require significant acquisition and implementation costs, but the healthcare utilization rates and any cost savings associated with their implementation have not yet been systematically quantified. We're in the process of completing our manuscript associated with this project, and we have intention to submit it for peer review and subsequently publish in the near future. So essentially then, the conceptual framework for our model suggests that digital patient navigation as a solution provides financial navigation to patients to help drive down rates of financial toxicity, thereby improving treatment adherence and reducing healthcare needs, further reducing healthcare resource use. That being said, Sarah asked me to speak on the utility of this calculator for healthcare decision making. Well, we see it as threefold. Essentially, it's to enable confident decision making, ameliorating point solution fatigue, and support sustainability and navigation programming. So from the top then, for confident decision making, this calculator helps make healthcare decision making regarding investment in digital solutions easier by allowing the end user to quantify how these solutions might indeed improve adherence, reduce acute care events, and ultimately produce cost savings. And in terms of ameliorating point solution fatigue, this calculator enables a healthcare system by providing a tool and a chance to fairly assess the value of solutions brought to them to enhance patient care and outcomes, ultimately increasing their ability to help make confident business decision making, And finally, in terms of supporting sustainability and navigation programming, this calculator is a quintessential piece of the business case for investing in scaled and sustainable patient navigation program. It is a data-driven approach to resource allocation, ultimately allowing the delivery of resources to help improve patient costs and access outcomes. In our manuscript, we're going to dive into it more so, but essentially, we've built a customizable tool to help users calculate the return on investment, which is a critical decision support solution on the pathway to scalable and sustainable patient navigation that will impact access, cost, and health outcomes for patients. Thank you very much.
Thanks so much, Carl. Really pleased to have Jake Centra on to introduce the second set of resources that we developed to really maximize the ROI that we've quantified with the ROI calculator. So Jake, please jump in here and let me advance the slides for you. But thanks so much for your remarks here, sharing out the blueprint, the second resource.
Yeah, thank you, Sarah. It's my pleasure to give a little bit more detail about the digitally enabled patient navigation blueprint, and specifically how patient navigators can use the blueprint to build upon that business case we've been talking about with the ROI calculator to really engage health systems leadership to get the buy-in for allocation of resources to patient navigation. Patient navigators can also use this blueprint to implement best practices for the design of patient navigation workflows that are standardized, something that's currently lacking. Patient navigators can use this blueprint to adapt existing EHR platforms to better support patient navigation, leveraging that existing tech. And we'll learn more about that in the upcoming panels today. And finally, the blueprint can be used to design patient navigation programs that are sustained by available reimbursement pathways, specifically the principal illness navigation pathway. And so next slide, please. There are 3 modules to this blueprint, and the first is designing your digital program. And here we present a set of program objectives that align with our guide program at UNC, where we present the initial programming priorities, where patient navigation teams, no matter their size or resource level, can identify those initial programming priorities for their initial allocation of resources, while also looking towards hallmarks of more mature programming supported by continuous program improvement. And this module also has a set of program considerations that outline the touch points with patients and care partners, the infrastructure needed for a comprehensive program design, the people involved, and the policies, both internal and external, to adhere to. The second module is Adapt Your EHR Platform, And here our partners at Epic and Oracle Health have brought together some overviews that are freely available to dive into how to adapt the existing tech, that EHR platform, to better support patient navigation, the workflows, and the reimbursement as well. And since Epic and Oracle Health cover nearly 60% of health systems combined, this is such a broadly applicable set of resources. And for their customers, behind the login, they have additional adaptation guides. And we're going to hear more about that in our first panel, so stay tuned. And the last module here that we have for the blueprint is develop your workflow and payment pathways. We'll get into that on the next slide, please. And so we present an ideal 3-phase workflow, and this is in recognition of the diverse set of experiences that patients and their care partners have when they go through their cancer care journey. And they may encounter patient navigation at different points in that journey, but because this workflow is standardized and linear, we can apply it to all of our patients, beginning with patient engagement and support, through integration of clinical and non-clinical navigation, and into digitally enabled patient navigation, intervention, management, and monitoring. And when we say standardized, we mean that each phase has 2 steps, and each step has an accompanying description, the actions that take place during that step, as well as what's triggered moving forward in the workflow, and the staff who are responsible for those actions and triggers. There are asterisks to provide even more in-depth detail, to be super comprehensive here when applying this workflow to your patient. And there's also reimbursement info for publicly insured patients through that principal illness navigation pathway, and commercial insured patients through the principal care management pathway. This workflow is supported by 2 more resources from this module, the first being a guide for digital distress and navigation support screening, where we equip patient navigators who are doing this digital outreach to do digital assessment for the risk of financial toxicity, and therefore referral to financial support services, but also even just screening for navigation support, so you can allocate resources effectively and meet patients where they're at and provide that ongoing active treatment outreach if that's what they need to attend their visits and support their care. Finally, we've got a reimbursement guide for non-clinical patient navigation. This is really centered around that principal illness navigation pathway, where we present a set of FAQs, some credentialing information for patient navigators who are billing incident to providers for these services, and a documentation checklist as well. We're going to hear a little bit more about screening and principal illness navigation in our upcoming panels, so I'm going to pass it back over to you, Sarah. Thank you.
Thanks so much, Jake. Really appreciate it. This is the overview of the 2 resources that we're really pleased to be able to launch today. It was a fantastic team that made these resources come to life, and we really believe in their capacity to improve patient access, cost, and clinical outcomes, as you just heard in our first session. The next panel of speakers here and the discussion we have upcoming is focused on the use of these resources to help identify patients in need of navigation support and to prioritize that support using existing technology. We have upcoming Kate O'Reilly, Vice President of Fund Development with Cancer Support Community, Linnea Van Pelt, Patient Services Manager in the Oncology Support Services Division at the University of North Carolina, Jason Wedge, Implementation Lead at Epic, and Susan Stiles, Director, Product Management, Oncology and Transplant with Oracle Health. I'd love to invite Kate up for 5 minutes of remarks here.
Thanks very much, Sarah. When we talk about why digital tools for health equity and financial toxicity are important in healthcare, it's also really important to us for us to think about who it affects. And evidence shows that social determinants of health account for more inequality in health outcomes than medical care. Financial toxicity, as we keep talking about, refers not only to the out-of-pocket costs, lost wages, and debt faced by cancer patients, but also the distress caused by that financial strain. In our 2023 study, the Cancer Support Community research showed that greater financial toxicity was associated with poorer quality of life in our rural cancer patients. 72% of rural cancer patients talk to their providers about cost. And more than half, 54% of them in this analysis, reported at least mild financial toxicity. 1 in 4 experienced high levels. This is a great opportunity for interventions like regular digital assessment to help identify barriers to care and highlight issues of financial toxicity. For those patients with high FinTox, their quality of life was influenced by talking to their healthcare provider about things like treatment costs and distress-related care. Our findings suggest that healthcare providers in rural oncology settings may benefit from tools and resources like this that further support communication with patients about costs, financial distress, and coordination of care. The cancer support community worked to integrate CMS's health-related social needs screener into our MyCare Report digital screening platform last year. The assessment looks at 5 core domains, namely housing, instability, food insecurity, transportation problems, utility help needs, and interpersonal safety. It also includes 8 supplemental domains, which are financial strain, employment, family and community support, education, physical activity, substance use, mental health, and disabilities. What we're seeing is that systematic screening of these elements helps both the healthcare provider and the patient and their family. Audrey Davis, our Senior Director of Health Equity, had this to say, and I quote, "Many patients and caregivers have lived through difficulties with accessing care and unmet needs their entire lives. They do not always know the terminology to describe their experience or that support is available for the nuanced barriers that they've encountered. The systematic health-related social needs screening helps not only put words to these experiences, but it also streamlines the process for resource linkage and reallocation by quickly identifying what is needed and highlighting trends and areas of opportunity for patient communities as a whole." I actually this week spoke to a hospital navigator to ask her what the health-related social needs distress screener did for her. And she said, assessing patient needs using a screening tool like the digital HRSN in a systematic way allows for quicker data collection and identification of the common barriers impacting our unique patient population. Also, as an accredited cancer center, there's federal and state institutions that require regular reporting. Ad hoc systems do not necessarily allow for us to collect that data. I also spoke to a cancer center director this week who said digital screening tools, particularly those that are self-administered like the HRSN, increase efficiency around clinical workflows. In busy cancer centers like ours, physicians and staff are often pressed for time during the standard medical visit. Because patient responses to HRSN are delivered digitally in real time before the actual physician visit, less time is spent interviewing the patient and more time is spent addressing the issues that are impacting and meaningful to the patient. The provider and staff overall save time assessing patient needs, and obtaining the HRSN data also results in more streamlined collaboration with other professionals. And finally, last but definitely not least, our patients. Most of a patient's life happens outside a hospital or a healthcare facility. They come to the table with complex issues that can't be put into a box while they manage their cancer treatment. Healthcare systems have long struggled to assist patients navigate some of these issues, and digital solutions and tools like the CancerX navigation blueprint can help move the needle for patient and healthcare outcomes and give providers tools they need excuse me, to both articulate the need, identify the need, and show population trends, provide on-demand support for patients. We're in a culture that has become reliant on an on-demand expectation, and healthcare is not exempt from this patient expectation. Patient satisfaction is linked to supporting and addressing these needs. And digital services help to identify these barriers. They increase the speed of connection to resources, and they produce personalized support for our patients. The patient gets that individualized, patient-centered care that's tailored to meet their needs. That results in improved healthcare outcomes for the patient and the institution. For navigators, having a tool like the ROI Calculator and the blueprint help make their case for bringing these vital elements to supportive care. Thanks, Sarah.
Thanks so much, Kate. We'll pass it over to Linnea for the health system perspective.
Hi, thank you so much, Sarah. And I would really like to just start by stressing what an honor it's been for our program and our institution to be part of this really important work. So here at the University of North Carolina in Chapel Hill, we've had just an incredible opportunity over the past couple years to build and engage with digital tools that are embedded in our electronic health record, and really use that to help us build out something new, which is a centralized patient navigation program that complements existing clinical nurse navigation. For a little bit of context, UNC is a large medical center, a large academic medical center located in an urban area. However, we are the state hospital, so we serve all 100 of North Carolina's very diverse counties, most of which are rural. Our oncology teams are highly specialized in their disease focus, and existing navigation services kind of evolved to have a very clinical focus and didn't really have a systematic way to assess and support patients for their non-medical barriers to care or their supportive care needs. So we had the opportunity to help build that out in a disease agnostic way, using new digital tools that really focused on those non-medical needs like social determinants of health. And it has really helped shape the care that we provide, I think in three main ways. One is, of course, equitable access to care, which I'll speak on in a moment. The other is our ability to better tailor our resources, which are not, unending, to specific needs that we know our patients have. And lastly, our ability to really better understand our patients on a population level and hopefully contribute to some of that research. So the digital tools that we helped build really were built to standardize how our patient navigators assess social determinants of health, many of which have been already mentioned, psychosocial supportive care needs, such as patients who live alone, and risk factors that we already know from the research can prevent patients from either accessing care in the first place or continuing and completing their cancer treatment. And this is really important because we are now proactively assessing all new patients rather than waiting for patients to volunteer information that can often be pretty sensitive. So by removing the burden and hopefully the stigma of quote unquote asking for help, it really allows us to start support for things like financial assistance, emotional distress, transportation, and other factors as early as possible, even before that first visit, which really serves to kind of open the doors for more equitable care overall. We've actually seen the needle start to move on this, which is really exciting, increasing the percentage of our new patients that get to that first appointment and also those who engage in treatment. So if we widen the lens just a little bit from a patient level and use this digital data we're collecting in an aggregate way, it also really allows us to better understand the needs and the barriers that are most common in our patient population, both as a whole, but also specific areas of the state. And that really helps us decide how to deploy our limited resources more effectively. For example, if we notice that transportation seems to be extra challenging for patients in specific rural counties, we can then dedicate some navigation time to building out a library of very specific resources for and from those communities, meaning we leverage internal, external, and also local agencies to kind of build a network of transportation support for all patients in that county. Another example, which is actually something we're working on right now, is we've noticed increasing number of patients whose financial assistance applications are being rejected due to incomplete or missing information. So in response to that, we have spent some time and are currently spending time training our patient navigators to really gain full confidence and capacity to fill out every single bit of that paperwork, helping patients collect documents and really facilitating the process from the very first step all the way through approval. And the last thing I'll note is, as we step back even further, having these digital tools that not only help us identify the patients that we should be reaching, but also assessing and collecting this really important data about them, it really gives us a powerful way of understanding patient need from a population perspective. And we hope that we will be able to contribute to the greater understanding of how and when and with whom financial toxicity is the greatest risk, as well as many other common threads like transportation, housing, food insecurity, and others. We know, of course, that personnel and resources are very expensive. And defining the need and being able to show the effectiveness of what we're doing will, we hope, continue to support our efforts to not just grow navigation, but also to grow supportive care resources overall. And at the end of the day, of course, the most important goal for all of us is to increase access to care and the ability for patients to continue high quality treatment for their cancer. That's really for all patients, but especially for those who have previously slipped through the cracks. And with that, I'll just end again by stressing how grateful we are for being invited to be part of this program. We're really proud to be part of this bigger community of others, like everyone on this call, who really share a passion for improving cancer care nationwide. Thank you so much.
Thanks in return, Linnea. Feeling is mutual on this side, and it's been a pleasure to work with you to co-develop this part of the resource. I'd love to pass it over to Jason Wedge and Susan Stiles to really talk about how we can use existing EHR platforms to support comprehensive patient navigation, to intervene with financial support, and of course, increase equitable access to cancer care. Jason, I'll pass it over to you here.
Great, thank you. Hi all, I'm Jason Wedge from the Epic Oncology team. And I want to start off by saying that Epic has standard out-of-the-box support for oncology navigation, and it requires no additional cost. So if you don't have this today, you can refer your IT team to the Oncology Navigation and Epic white paper that's on Epic's user web. Anyone with an Epic login can access the white paper, which includes more detailed explanations, screenshots, training materials, and more details on customer outcomes. So you can facilitate oncology navigation in Epic by setting up the workflows and allowing navigators and their managers to perform each of the items shown here on the screen. I'd like to translate that into some of the key tools used to support these workflows in Epic's foundation system. Next slide, please. First, Epic's foundation system is an instance of Epic where we've configured best practice workflows and content. We made it easy for your IT teams to directly incorporate the latest and greatest enhancements for oncology navigation. That includes oncology navigation dashboards. This helps you identify patients, assign navigators, track tasks, and measure productivity. With the oncology navigation episode, this is created on your first patient navigation encounter and begins the longitudinal tracking of your patient. Episode checklists include standardized groups of tasks and also allows you to create patient-specific tasks, all with clear owners, due dates, and a dashboard to make sure nothing slips through the cracks. Patient outreach encounters is where your staff have a dedicated workspace for oncology navigation work. MyChart is Epic's patient portal. It's used for a variety of key navigation-related items, including SDOH screening, eSIM, or electronic symptom monitoring for active treatment patients, and providing patients with educational material through patient instructions. So all of this information collection can be gathered through MyChart, but it can also be collected through routine care, such as the rooming process in the waiting room before an office visit, and also by navigators performing outreach. Regardless of how you collect this information, it's all filed into the system, into the same locations for seamless review and trending over time. One additional detail with the patient instructions, Epic has partnered with the American Cancer Society to make it easy for you to share ACS content directly in workflow. In August, we released materials focused on newly diagnosed patients, including materials also for clinical trial participation. This content is available in 12 languages. Flow sheets, in addition to the standard assessments, also includes a specific oncology navigation flow sheet, and this allows clear documentation for key details specific to your oncology navigation program. And then lastly, the charge capture navigator section allows capturing the appropriate charge codes in routine workflow to make sure you get paid for all the hard work you're doing. The tools in the foundation system encompass clinical and patient navigation, so workflow customization is possible based on organizational needs. I'd also like to highlight a few outcomes. Mayo Clinic presented earlier this year using the standard Epic Foundation System content to support their oncology nurse navigation program. In 2023, that program included 25 nurse navigators and over 7,500 patients. And with this, they saw a 24% increase in documented interventions per navigator, consistently lower no-show rates for infusion visits, and a reduction in time from the initial referral to treatment for surgical and radiation oncology patients. Another key outcome that you see on the screen here relates to eSIM, electronic symptom monitoring, within Epic's patient portal, with system questionnaires related to a patient's symptoms and interventions to educate the patient. A consortium of 6 Epic sites, including Dana-Farber, Dartmouth, Baptist, Lifespan, Maine Medical Center, and WVU, patients who used eSIM were significantly less likely to have an ED visit or admission. These outcomes were presented at ASCO this year, and many organizations are turning on eSIM as part of their overall navigation program. In closing, I'll give one last plug. For more information on these outcomes and to get started on this work, refer your IT team to the Oncology Navigation and Epic white paper on Epic's user web. Thank you.
Thanks so much, Jason. We'll be able to drop the link in the chat here for the webinar panelists and participants. It's also available within the CancerX resources that we've released today. Over to you, Susan, from Oracle Health, to do a corollary presentation.
Thank you, Sarah. Let me first say that we also have really enjoyed being a part of this initiative and working together with DIME and CancerX on nurse navigators and financial toxicity. So for the Oracle Health and formerly Cerner Corporation, oncology nurse navigators, we know, provide incredible assistance to patients, families, and caregivers to help navigate and manage the whole healthcare system. It's overwhelming, the type of care and treatments that patients go through. So our nurse navigator work list, we have several things that I'll show today. It starts off with the navigator work list, which really kind of looks like a task list for ability to do the work that's needed by a nurse navigator. This can also be filtered or configured to be around a survivorship navigator if they're only doing survivorship, or they can do overall treatment or even screening type navigators. So it can be really configured around that. The patient list enables them to track and manage the patient's care, limiting the need to double document an alternative systems. So everything can be in one system with their EHR. The patient work list also displays important information with direct access for the full chart and be customized to display a specific clinic, disease type, or their needs. It also enables a navigator to focus on specific criteria at any given time. So being able to filter and figure out exactly what you're trying to find to take care of that patient's needs. And then our workflow end pages are tailored to meet clinical documentation requirements to support the CMS billing initiatives. The link at the bottom is really how you can click on that if you're an Oracle Health client to go to our reference pages and be able to see more information. Next slide. This is just a little closer view to be able to look at that nurse navigator work list. As you can see, it's really like a task list with the patients that you have to work on for that day. And then it kind of gives you top information about that patient. You can filter it to look at future appointments, kind of look at where their journey's taking them, what's happening with them, so that you can address those needs at any time. And then if you click to the next slide, you'll see our nurse navigator workflow end page. So once you click on a patient from that work list, you will then go into this page where you can actually see every piece of the patient's chart, all the way through all the different pieces of the work list, which is on the right side. And so this workflow end page brings everything from the chart up forward for the nurse navigator to work through each piece of what they're doing and be able to then document their care and the discussions they've had and even next steps or to-dos. So we definitely have things that support the nurse navigator's workflow throughout Oracle Health. And this is a part of our oncology product as well. So this does not cost extra if you own Oracle Health Oncology. This is a new feature within that product. And more to come in the future as we continue to work on this. So thank you.
Thanks in return, Susan. Really appreciate all of the speakers here today for the time they shared with us and the remarks they shared with us. They were each invaluable to the development of these resources. And to round us out, to discuss how the resources and newly available payment pathways can and are being used to support sustainable digital patient navigation, we have a message from Annabella Aspiras, Assistant Director, Cancer Moonshot Engagement with the White House Cancer Moonshot, and a lessons learned presentation from Danielle Brown, Senior Director of Care Coordination at the Florida Cancer Specialists and Research Institute. So just a quick note from Annabella before we pass it over to Danielle.
Hi there, I'm Annabella and I lead public engagement for the Cancer Moonshot. I'm sorry that I'm not there with you live, but I'm excited to pre-record these remarks for our amazing colleagues at CancerX and for this incredible audience. For those who might be less familiar with the work of the Cancer Moonshot, the President and First Lady reignited the Cancer Moonshot almost 3 years ago as a national effort to end cancer as we know it. We have two bold but we think achievable goals. The first is to decrease the death rate from cancer by at least 50% in the next 25 years, preventing more than 4 million cancer deaths by 2047. And the second is to improve the experience of people living with and surviving cancer. Navigation is critical to both of these goals, which is why the President made establishing a way to pay for navigation services a top priority. Like this group knows, navigation has been shown to improve patient outcomes, to lower healthcare costs by preventing unnecessary health system utilization, and to reduce health disparities by facilitating access to services that address unmet health-related social needs like transportation and food and housing insecurity. So last year, thanks to transformative leadership from the First Lady, the Biden Cancer Moonshot delivered 6 codes that can be used to report navigation services for payment. These include 2 net new codes from CMS. These are principal illness navigation codes, and they encompass services that address unmet social determinants of health, and 4 CPT codes for principal care management, which the American Medical Association updated the guidance for these CPT codes so that they could be used to report clinical navigation services. Now that these codes are live, we are talking to audiences like you to raise awareness that these critical services can now be reimbursed, and that reimbursement will help ensure that navigation services scale and reach every patient and family who needs them. In addition to saving health systems money by preventing costs, as I mentioned earlier, the new navigation codes present important revenue generating opportunities for healthcare practices. That said, adopting and implementing the codes in order to access that navigation ROI isn't that simple. You have to update coding and billing operating systems as well as the EHR to ensure that frontline staff are documenting navigation interventions. You have to train staff, including coding and billing staff, on the correct use of the new codes and how these codes will affect claims processing and reimbursement. You have to train frontline staff in terms of documenting services correctly. You have to communicate with payers so that they understand impacts to your work. You have to achieve executive sponsorship from hospital leadership. And like any new initiative, you have to monitor and evaluate utilization to understand if there are gaps and to evaluate patient satisfaction and outcomes. And so this is why all of that work is why we are so excited that CancerX will be launching a set of navigation resources aimed at helping health systems leverage existing technology, access the ROI of new solutions, and standardize their clinical and billing workflows to support scaled and sustainable patient navigation. Efforts like this are a huge part of what is needed to ensure equitable access, adoption, and availability of high-quality navigation services. I want to say thank you to CancerX and all of the dedicated and talented folks on this call, including the other amazing speakers. Hi, Danielle. Thank you for sharing and advancing the work of the Cancer Moonshot to end cancer as we know it. Have a great meeting, and over to you.
Great. Wonderful remarks from Annabella and a really great introduction for Danielle. Please take it away.
Sure. Hello, everyone. My name is Danielle Brown. I'm the Senior Director of Care Coordination at Florida Cancer Specialists. We started looking into principal illness navigation and really working on this internally early January when we first kind of heard about these codes and how to utilize them. And myself and some of our teammates and our great informatics team really worked together to see how do we build this internally. I would have loved to have had a ROI calculator and a blueprint and everything to do those things. And we didn't have that then. So we kind of just started building internally on our own. We started making sure all of our nurses and our non-clinical support staff were trained. They took the GW course, but there are many out there, AONN, NCBC, ACS Lion. Just make sure you check your state's recommendations. But we started that way, and then we kind of made our own internal blueprint, just working through all of the things that are now put together for you guys all to use in your own practices. We're about our 6-month mark thus far, and we're starting to pull together some of our early data to really share with everyone at the Moonshot and beyond of what navigation has been able to do for our practice for these patients. Early initial looking at it, we've seen multiple barriers to care addressed, housing issues, financial issues, just really starting to see the impact of care for our patients. And really to be able to prove the ROI is invaluable. It's great. And the only way we can really scale this now is to get more support, more tech tools, those sort of things to have that digital reach. So we're really excited. I was lucky to get to test the ROI tool and really plug in some different numbers of softwares and things that I'd want to use one day to take this a little bit further. And it was great. It was great. And it helps to tell the story of what you need in your practice and what that return on investment can be. So really excited for these tools, Sarah, and we appreciate being a part of this and love to share any additional help that we can with the team. But we've been going at it now for about 6 months, and there has been a return on investment. You know, like they say, you know, this wasn't meant to cover a full FTE or anything like that. So we're not quite there yet. But we were already doing navigation here at FCS because, like Sarah said, it's just the right thing to do for our patients. So it's great to be doing the work we were already doing and just being able to enhance it and then show the value, which that ROI calculator really helps us to be able to do. So thank you. Thank you to the DIME team and all the other participants.
Thanks in return, Danielle. Really, really wonderful to hear that you're already seeing some ROI generated from the implementation of these PIN codes to support services that you are already providing, that are the right thing to do, and that increase access, reduce costs for patients, and overall improve clinical outcomes. We would love to thank the rest of our speakers for a job well done today. It's a culmination of a lot of hard work, and we're really pleased to be able to get these out into the world for immediate uptake. We also want to thank the audience for tuning in and issue a call to action here. We hope that you find the resources launched today useful in your decision making. We hope you use them to quantify and to maximize your ROI. And we hope that you'll join us in future work related to digital navigation. We've got an upcoming project related to the role of digital navigation in clinical trial recruitment, enrollment, and retention. We encourage you to scan the QR code here, fill out the interest form if you're interested in working with us. It's always a pleasure to be able to release these resources out into the world. And we hope the process is a pleasure as well for the group. Finally, I'd like to end with a sincere thanks to the project team. We've thanked them many times throughout. I don't think there are enough thank yous to go around to this group here who we've worked with over the past 18 months. Because of your dedication to improving patient outcomes, we have been able to pull these resources together, and only because of that. We are incredibly grateful for your partnership, and we are really pleased to be able to release the ROI calculator and the digital patient navigation blueprint for use in the real world. So thanks so much again to the speakers, to the project team, and of course to the audience for your attention. We'll close out a minute early here and give you all the best as we do. Take care, everyone.